Hello guys, welcome to my channel. So this is the part 2 of our ECG series. In this video, I'm going to be sharing the classical ECG strips and certain disorders seen in the ECG. So starting with that, we have the ECG of sinus tachycardia, and this is the sinus rhythm. As you can see, we can appreciate the all the waves like P wave and QRS complex, and there is the T wave and ST segment PR interval. All of this is appreciable in on this strip, and sinus tachycardia is actually just the increase in the heart rate of more than 100 beats per minute, and this is the normal sinus rhythm. It can be due to certain reasons like anxiety or other causes as well. So this is the sinus tachycardia. Now we have another ECG, and this is actually the ventricular tachycardia. As I've already told you in the previous video, that the ventricular tachycardia is actually the wide QRS complex seen in the ECG, and no P wave can be identified on this ECG strip. And we have the ventricular tachycardia and SVT. So how can we differentiate between the two? Actually, SVT is from above the ventricles, and ventricular tachycardia originates from the ventricles. So the QRS complex is wide, right? And the rhythm is fast, and QRS complex is wide. On the other hand, in case of SVT, in case of SVT, as you can see, there is the rate increased, heart rate is increased, but there are QRS complexes which are narrow. So rate is increased and narrow QRS complex is there, but PR and P waves cannot be identified as much. This is not the sinus rhythm. So you can differentiate between these two, SVT and ventricular tachycardia. It is very important that you are able to differentiate between the two, because SVT is the narrow complex tachycardia, because it is coming from above the ventricle, and fast rhythm plus narrow narrow QRS complex, it is SVT. And if there is the fast rhythm and the QRS complex is wide, that is the ventricular tachycardia. Now we have another ECG, that is the ECG of atrial flutter. As you can see, there are the sawtooth appearance of the P waves. So actually, in atrial flutter, atria are contracting at the rate of 300 beats per minute, and this is actually causing the sawtooth appearance of the P waves. So this is actually the atrial flutter, and atrial flutter can also be regular and irregular. So do not confuse with the rhythm, as it is irregular. So you do not have to say it as the atrial fibrillation, because as you can see, the QRS complexes and the ventricular fibrillation, ventricular contraction is not much increased, and the rate of ventricular rate is not much increased as compared to the atrial rate, and the atria are contracting at much increased rate, which is appearing as the sawtooth appearing P waves. So this is the atrial flutter. On the other hand, in case of atrial fibrillation, we have now this is the case of atrial fibrillation. As you can see, the ventricular rate is increased and the rhythm is irregular, and there are no sawtooth appearance of the P waves. So this is the ventricular atrial fibrillation. So in case of atrial flutter, there are P waves present, but in the shape of sawtooth. And in the cases of atrial fibrillation, there are no P waves or PR interval appreciable, and the rate is 100 to 150, and the pulse is and the rhythm is actually irregular. Pulse is appreciated in the cases of atrial fibrillation. Now, if the atrial fibrillation is not treated, it can lead to the ventricular fibrillation, and ventricular fibrillation can also occur due to other causes, like the severe hyperkalemia. So, ventricular fibrillation is actually the chaotic irregular deflection seen in the ECG, and rate is actually ventricles are actually contracting at the rate of 150 up to 500 and there are no P wave, QRS, no P wave, no QRS complex, or no T waves are appreciated on this ECG. And the as the duration keep on increasing in the case of ventricular fibrillation, the coarse ventricular fibrillation gets turned into the fine ventricular fibrillation, and progressively it can turn into asystole if the patient is not treated urgently. So ventricular fibrillation is very lethal. It has to be treated very efficiently. Now we have another case quite similar to the ventricular fibrillation, is the torsades, and the torsades are actually the polymorphic ventricular tachycardia. It is actually similar to the, it can be similar to the ventricular tachycardia because it has also the wide QRS complex and the rate is increased. But as you can see in the same lead, there are the waves of different morphology. So this is actually the polymorphic ventricular tachycardia, and it is the torsades, and rate is highly variable and rhythm is irregular. It is actually also called as the twisting of the points, and there is wide QRS complex, and there are multiple causes of torsades. Actually, there are some precipitating factors for torsades that are the drugs, drugs commonly antipsychotic drugs, macrolides, methadone, and ondansetron can cause torsades, and also the electrolyte imbalances like hypokalemia, hypomagnesemia, and hypocalcemia can cause the torsades. So it is very lethal. And it is the QT interval is increased in long QT interval and polymorphic ventricular tachycardia. It is defined as by these two features. So this is the torsades, and this is also the torsades. As you can see in the same lead, there are polymorphic appearance. On the other hand, in the ventricular tachycardia, there is monomorphic appearance of the waves. This is also another example of torsades. Now we have the case of severe hyperkalemia, and as you can see, there are tall tented T waves, which later on are converting into the sinusoidal waves. So these are the tall tented T waves. So sine wave ECG pattern, and it which is leading towards the ventricular fibrillation. And there are three main changes that occur in the ECG if the potassium keeps on increasing. Earlier there are tented tall peaked T waves, and progressing, if it is progressing, so there is a decrease in the height of P waves and increase in the length of PR interval, which means that there is slow conduction through the atria. And the potassium, if the potassium keeps on increasing, there is widening of the QRS complex, which then merges with the T wave, and there is the characteristic sinusoidal pattern, which is signifying the severe hyperkalemia, and it can eventually lead towards the ventricular fibrillation. So you have to keep in mind three main characteristics on the ECG of hyperkalemia. Earlier, they are tented and a peak T wave. Then later on, there is a slight decrease in P wave and increase in the length of PR interval, then widening of the QRS complex, and then they merge with the T waves, and there is the characteristic sinusoidal pattern. So this is the classical ECG of severe hyperkalemia. Now we have another very important case of this is the ECG of Wolff-Parkinson White syndrome, and as you can see, there are these slurred QRS upstroke. Wolff Parkinson White syndrome can be signified by the delta wave, which is actually the QRS upstroke like appearance. And as you can see, this is the delta wave, and there is the PR interval. There is the decrease in the PR interval, shortening of the PR interval, and appearance of the slurred QRS upstrokes. That is the delta wave. So this is the characteristic of Wolff Parkinson White syndrome. These upstrokes of the QRS complex. These are significant for this syndrome. Now I'm going to start our three classical cases of ST elevation MI. So in this case, as you can see, there are the ST elevation. First of all, we're going to start with our chest leads that are V1, V2, and V3. In V2, there is a classical ST elevation in the V2 lead, and there is also the ST elevation in the V3, and V4, V5, and V6. So these are the anterior chest leads, and the ST elevation is classically seen in these five leads. And on the other hand, we have the ST depression in the 2, 3, and AVF. As you can see, this is the isoelectric line, and the ST segment is slightly depressing itself. So there is the ST depression, and there is also the ST depression seen, and in the AVF there is also ST depression. So this is the classical case of anterolateral STEMI, anterolateral ST elevation MI. Now we have another case of ECG. As you can see, first we are going to see the chest lead V1, V2, and V3. And there are no significant changes. And V2 there is a slight increase in the ST elevation. And in leads 2 there is ST elevation. Lead 3 there is also the ST elevation. As you can see, this is the isoelectric line, and the ST segment is elevated. Also, in the case of lead 2, there is ST elevation, and there is no ST elevation in lead 1 or VR, AVR, AVL. There is no ST elevation, and in the case of AVF, there is also, this is the isoelectric line, and this is the ST segment elevation. So this is the classical case of inferior wall MI, where we see the ST elevation in the leads 2, 3, and AVF. Now we have the case of posterior MI, posterior myocardial infarction. As you can see, we have the anterior chest leads, and you can see the dramatic ST depression in these leads V1, V2, V3, and V4. The anterior leads have a dramatic ST depression, and that is equivalent to the upside down of the ST elevation. And in the case of posterior MI, we have to actually check the mirror view. Imagine flipping the ECG paper over and looking at it from the behind, so you would see the ST elevation in these chest leads. And also posterior MI can also be defined, can also be suspected in this patient, as this patient is having the bradycardia, because the posterior, the vessel supplying the posterior part of the heart is also supplying the SA node. So there would also be the bradycardia associated with these ST depression in these chest leads. And if, on the other hand, if these chest leads are having the ST elevation, simply they are referred to as the anterior STEMI. It would be seen in the anterior STEMI, but in the anterior STEMI there wouldn't be the bradycardia. And if there is ST depression in these chest leads and there is bradycardia, you are going to suspect the posterior MI. Now we are going to do our heart block ECGs. So first of all, we have the first degree heart block, and in this case, as you can see, there is PR interval constantly. There is PR interval more than 200 milliseconds, and the PR interval is longer, and this is the case of first degree heart block, and there is no dropping of the QRS complex. So it is simply the PR interval prolongation, and it is the first degree heart block. Then we have the Mobitz type 1, that is the Wenckebach heart block and Wenckebach phenomena. And as you can see, there is PR is gradually increasing. So PR interval is gradually increasing and the QRS drops. Then again, there is PR gradually increasing and the QRS drops. So this is the case of Mobitz type 1, and it is the Wenckebach. And then we have the Mobitz type 2, in which there is constant PR interval is constant, but there is the drop of QRS complex randomly. So we can differentiate Mobitz type 2 from the first degree heart block is that in both of them there is PR interval prolongation, but and PR is constant, but there is no drop of QRS complex in the first degree, while in the Mobitz type 2 there is the drop of QRS complex. And now this is the third degree heart block, and in this case, as you can see, P waves and QRS complexes are occurring independently, and it means that atria and ventricles are beating independently. and they have no relationship between them, and it usually occurs in the cases of Lyme disease, congenital lupus, or diphtheria. In the first part of our video, in the first part of the ECG series, I have discussed the no, axis deviation. So how can you see the axis deviation? For seeing axis deviation, you have to see the leads 1 and leads AVF. So if both of them are stroking upwards and both of them are facing upwards, that would be the normal axis. But in this case, as you can see, this is the right bundle branch block. Why is it the right bundle branch block? Because the lead 1 is negative and lead AVF is positive. Both of them are facing towards each other. So if these two leads are facing towards each other, it means that it is the right bundle branch block. And that is the right axis deviation, right? On the other hand, in the cases of left bundle branch block, lead 1 and AVF would be facing away from each other. That it means that lead 1 would be facing upwards. That means it would be positive, while the lead AVF would be negative. So they would be facing opposing each other. You can remember it like that. If both of the thumbs are up, it would be normal axis, and if both of the thumbs left each other, it would be left axis deviation, and that would be the left bundle branch block. And if both of the thumbs are towards each other, both of them are facing towards each other, facing each other, that would be right axis deviation. That means right bundle branch block. So these are some of the important ECG patterns and ECG strips you have to memorize for the AMC. And I tried to make it easier for you. If you find it difficult, if you find it easier, kindly subscribe my channel and like my video and share among your colleagues. Please share your feedback also. Thank you.